All right, so we're moving on to episode 5 of antimicrobial resistance series, favorite program, Global Health Decode. Today's one is titled Stewardship, 15 to 30%. So let's get ahead. Now, 30% of antibiotic prescriptions are unnecessary. Full stop. Hospital stewardship programs reduce broad spectrum use by 40% without compromising outcomes. We can buy time with the antibiotics that we already have. I'm Dr. Anthony Anaweokhai. On this channel, we decode global health through evidence-based analysis, one crisis, one solution at a time. This content is educational based on WHO 2024 to 2025 data and CDC reports. It's not medical advice. For antimicrobial prescribing or stewardship implementation, consult qualified healthcare professionals and infectious disease specialists. Antimicrobial stewardship represents coordinated interventions designed to improve and measure appropriate antimicrobial use. The goal is to optimize clinical outcomes while minimizing unintended consequences, including antimicrobial resistance, adverse effects, and healthcare costs. Right drug, right dose, right duration. Now, this concept emerged in the 1990s as infectious disease specialists recognized that inappropriate antibiotic use accelerated resistance development. Studies demonstrated that 30 to 50% of antibiotics prescription in outpatient settings were unnecessary or inappropriate. In hospitals, broad spectrum antibiotics were used when narrow spectrum alternatives would suffice. United States Centers for Disease Control defines core elements of hospital antimicrobial stewardship program. Leadership commitment provides necessary authority and resources. Accountability designates specific individuals responsible for program outcomes. Drug expertise ensures access to infectious disease and pharmacy specialists. Action implements policies to improve prescribing. Tracking monitors antibiotic use and resistance patterns. Reporting provides regular feedback to prescribers. Education disseminates evidence-based prescribing guidelines. Now, all these elements translate into concrete interventions. Prospective audit and feedback involves reviewing antibiotic prescription within 48 hours and recommending modifications. Formulary restrictions require authorization before prescribing specific broad spectrum or last resort antibiotics. Clinical pathways standardize treatments for common infections. Dose optimization ensures adequate drug concentrations while minimizing toxicity, while the duration optimization limits treatment to evidence-based timeframes. The World Health Organization Global Action Plan on Antimicrobial Resistance, updated through 2024 to 2026, identifies stewardship as a critical intervention. Every country committed to implementing national stewardship standards. However, implementation varies dramatically across healthcare systems. For instance, high-income countries with robust infectious disease infrastructure implement comprehensive programs, whereas low and middle-income countries face resource constraints limiting program scope. Yet, the principles apply universally. Appropriate prescribing benefits patients regardless of settings. As usual, we begin with a quote. The physician William Osler thought, the good physician treats the disease. The great physician treats the patient who has the disease. Stewardship extends this wisdom, treating the right disease with the right drug for the right duration. So there's evidence of effectiveness. The evidence supporting antimicrobial stewardship is substantial. Systematic reviews and meta-analysis consistently demonstrate that well-implemented programs reduce antibiotic use by 15 to 30% without increasing adverse outcomes. 15 to 30% reduction in antibiotic use without harm. Research published in the Lancet Infectious Diseases examined outcomes from 216 stewardship interventions across multiple countries. Programs implementing prospective audits and feedback reduced broad-spectrum antibiotic use by 40%. Length of stay decreased by 1.2 days on average. Hospital costs fell by 12%. Mortality rates showed no increase. In some studies, mortality decreased as stewardship reduced Clostridioides difficile infections caused by excessive antibiotic use. The mechanism behind these improvements involves multiple pathways. Stewardship programs identify patients receiving antibiotics without documented bacterial infections. They transition intravenous antibiotics to oral formulations when clinically appropriate, thus reducing complications from vascular access. They discontinue antibiotics when infection resolves rather than completing arbitrary 10 to 14-day courses. Duration optimization proves particularly impactful. Traditional teaching recommended 10 to 14 days of antibiotics for most infections. Contemporary research demonstrates, however, that many infections resolve with shorter courses. Uncomplicated pneumonia responds to 5 days of therapy. Urinary tract infections require just 3 to 5 days. Intra-abdominal infections treated successfully with surgical drainage needed only 4 days of antibiotics. Studies from Johns Hopkins University documented the stewardship program reducing mean antibiotic duration from 8.3 days to 5.1 days for surgical patients. Surgical site infection rates remain stable. Clostridioides difficile infections decreased by 35%. Antibiotic costs fell by 28%. And the U.S. Veterans Health Administration implemented system-wide stewardship across 170 hospitals. Over 5 years, broad-spectrum antibiotics use decreased by 30%. Multi-drug resistant organism rates stabilized, then declined. The program avoided an estimated $370 million in healthcare costs while improving patient outcomes. These results demonstrate that stewardship is not merely harm reduction, it actively improves clinical care while preserving antibiotic effectiveness. So, what are the implementation barriers and what can be some solutions? Now, despite compelling evidence, stewardship implementation faces significant barriers. Understanding these obstacles informs strategies to overcome them and achieve widespread adoption. 68% of countries have stewardship plans, only 10% funded. Resource limitations constitute a primary barrier in low and middle income countries. Stewardship programs require infectious disease specialists, require clinical pharmacists, require microbiologists. These are expertise that's often unavailable in resource-constrained settings. Laboratory capacity for culture and susceptibility testing may be limited or even absent. Electronic health records enabling prescription tracking and audit may not even exist. The World Health Organization addresses this through tiered implementation guidance. Even basic stewardship, something as little as developing antibiotic formularies, creating treatment guidelines, and tracking aggregate antibiotic consumption provides benefits. Advanced interventions requiring specialized personnel can be phased in as capacity develops. Cultural barriers persist even in well-resourced settings. For instance, physicians may resist oversight of prescribing practices, viewing stewardship as questioning clinical judgment. Patients sometimes, surprisingly, demand antibiotics for viral infections, creating pressure on prescribers. Hospital administrators may prioritize other quality metrics over stewardship. Overcoming these barriers requires multifaceted approaches. Leadership engagement from hospital executives and department chairs legitimizes stewardship initiatives. Education, emphasizing stewardship as supporting rather than policing prescribers, reduces resistance. Patient education campaigns explaining that viral infections do not benefit from antibiotics decrease inappropriate demand. Behavioral science insights enhance implementation. Peer comparison feedback, showing prescribers how their antibiotic use compares to colleagues, motivates appropriate prescribing without punitive measures. Defaulting ordering systems requiring active justification for broad spectrum antibiotics reduce inappropriate prescriptions through choice architecture. Antibiotic prescribing and use in doctors' offices study by the CDC tested behavioral interventions in primary care. What did it find? That clinics where prescribers received peer comparison letters reduced inappropriate prescribing by 12%. Clinics that added patient education materials achieved 18% reductions. Technology facilitates stewardship. Electronic prescribing systems can provide real-time clinical decision support, suggesting narrow-spectrum alternatives when prescribers order broad-spectrum drugs. Automated alerts flag patients receiving prolonged antibiotic courses for review. So what's the global implementation status? Global progress on stewardship implementation reveals substantial variations. Global progress on stewardship implementation reveals substantial variation. The WHO's 2023 Global Study of Antimicrobial Resistance and Use provides current status across member states. 178 countries have national action plans. 178 countries developed national action plans on antimicrobial resistance as of 2023. Now, these plans include stewardship commitments. However, actual implementation lags significantly. 68% report some stewardship activities, while only 25% have costed and budgeted programs. 10% allocated financial resources specifically for stewardship. High-income countries demonstrate the most comprehensive implementation. The UK mandated stewardship programs in all NHS hospitals. The US requires stewardship as a condition of hospital accreditation. Australia integrated stewardship into its national quality and safety standards. Middle-income countries show variable progress. Thailand, for example, implemented robust stewardship nationally through its universal health coverage system. South Africa developed stewardship guidelines, but implementation remains inconsistent. In India, stewardship efforts face challenges from over-the-counter antibiotics availability. Low-income countries struggle most significantly. Limited laboratory capacity prevents culture-guided therapy. Shortages of narrow-spectrum antibiotics force reliance on broad-spectrum drugs. Personnel shortages need no dedicated stewardship staff. These challenges require international support and capacity building assistance. The Global Antibiotic Research and Development Partnership assists low-resource countries in developing contextually appropriate stewardship programs. Emphasis falls on implementing core components feasible within existing resources rather than requiring infrastructure investment that countries cannot afford. I'll give you another quote. Perfect is the enemy of good. Waiting for ideal conditions prevents implementation. Beginning with feasible interventions provides immediate benefits while building towards comprehensive programs. So what's the path forward? The path forward requires sustained commitment at multiple levels. Individual prescribers must emphasize evidence-based prescribing practices. Healthcare facilities must implement and adequately resource stewardship programs. National health systems must establish policies supporting appropriate use. International organizations must provide technical and financial assistance for global implementation. Stewardship preserves antibiotics for future generations. The business case for stewardship strengthens as evidence accumulates. Programs reduce costs through decreased drug expenditure, shortened hospital stays, fewer complications from antibiotic-associated adverse events. The return on investment studies demonstrate that every dollar invested in stewardship generates $3 to $5 in cost savings. Patient advocacy groups increasingly recognize stewardship importance. Organizations such as the Pew Charitable Trust and the Alliance for the Prudent Use of Antibiotics educate the public about appropriate antibiotic use and resistance risk. Stewardship alone cannot solve antibiotic resistance, but it buys time. It preserves existing antibiotic effectiveness while other interventions develop. Combined with reduced agricultural use, improved infection prevention, and combined with the new therapeutic development, stewardship forms an essential component of comprehensive response. Quote this: Benjamin Franklin wisely noted, an ounce of prevention is worth a pound of cure. In antimicrobial resistance, appropriate use prevents resistance development far more effectively than attempting to treat infections once resistance emerges. Healthcare professionals, what stewardship interventions work best in your setting? Share your successful strategies in the comments. 30% of antibiotics prescribed unnecessarily. Stewardship program demonstrates that reducing inappropriate use improves patient outcomes while slowing resistance. The evidence is clear, implementation is feasible. Every healthcare setting can begin. The 15 to 30% solution buys crucial time while addressing discovery drought and agricultural misuse. Stewardship represents our most immediate cost-effective intervention. We must act now. On the next episode, we'll be looking at global health sovereignty. Why local antibiotic manufacturing matters for pandemic preparedness and resistance containment. Do not forget to hit the like button. Subscribe to Global Health Decoded. Instagram, TikTok, Facebook, LinkedIn at Global Health Decoded. Next episode, we'll look at global health sovereignty. Did we nail this? Maybe, maybe not. Always fact-checked, always peer-reviewed. Dr. Anthony Iyore Anaweokhai. See you next time.